We're going to start off giving a bolus of approximately 12 to 14 mils while watching her response over 10 minutes. We're going to let the pump run at 100 mils per hour. So we're going to do this at approximately 12 to 14 mils as a bolus while watching her response, talking to her all the time. When we get to that, which should take approximately 10 minutes, we're going to reduce her rate to approximately 10 mils per hour.
And she's had how much midazolam?
She's had so far 3.5 milligrams. She's had no narcotic at this stage. She's 55 kilograms. So that's a fairly high dose. But the reason we're using a fairly high dose in her is because she's young. She's really healthy and she's not pharmacologically naive. She's accustomed to a lot of painkillers. What you'll find very, very gradually, you'll start getting drowsy. You won't fall asleep completely. Okay? But very, very drowsy. It isn't very painful. She's had a very low pain threshold. High drug requirement, low pain threshold. A little bit of burning in your back. You with her, Georgia? You still there? Just speak in a nice loud voice when you want to speak to me, okay? I want to hear you. 50 mics of fentanyl. That's not going to make you go to sleep. I'm going to stop this at 13 mils. And so after she's had a total of 13 mils of the bolus, we're now running an infusion of 12 mils per hour. And she's got chronic back pain, which is not responding to any medication. What we're doing is a trial of spinal cord stimulator, which means he's going to pass electrodes into epidural space. We're going to stimulate it, and hopefully she's going to tell us if the stimulation is where we want it to be. So the important thing for you to know now is that she can actually talk to us.
Okay, George, I'm going to turn on the noise stimulator. You just let me know where you're feeling it, okay?
We want to obviously have her sedated, comfortable, but responding and talking to us.
Anything different happening yet? How about now? Are you starting to feel any tingling? How about now? Your left thigh, right thigh. Your pain is in your left leg though, isn't it? Okay.
So if we would use your table, we would have given her, according to this one, 13 and almost 14 mils, slightly slower rate than I gave it. I was using 100 mils per hour and rather than 82, but the dose is very similar. And the infusion rate would really depend. Here, they've got an infusion rate, the maximum of just under 14 mils. We're giving her near the top of the range, but that's because I know she's going to require quite a lot. Georgia? Hi there, love. You can stay awake for us, you can talk to us.
Okay, I'm just turning on the stimulator again, okay? You let me know where you feel the tingling. You feeling any tingling yet? Your left leg?
Okay.
And when you said the other thigh, does that mean you could feel it in your right thigh as well? Just your left thigh? Okay, so it's the back of your leg and the front of your left thigh. Is that comfortable, Georgia? Yeah, of course. I'll just test a bit further down. We'll see if we can get further down in your leg.
I don't think that, for example, Precedex is an ideal drug to be used on the outpatient. Not something you want to send home the same day. She's breathing spontaneously all the time. She's at a saturation of 100, she's been fully saturated. She's able to talk to us. The pulse, in fact, is not gone down in this case. She's been very, very, very stable. BP has been okay. It's very between 100 and 104, so there's been no drop in her blood pressure at all. How are you doing, Georgia? She's okay, so she's still talking to us. And we'll switch it off in the short. I think that it causes a lesser drop in blood pressure, a lesser change in hemodynamics than what we used to use before. what could be seen as an advantage or a disadvantage depending on the sedation post-operatively lasts for a good hour or so. The patient feels very sedated, but that's what we're trying to really do. So I personally would not use it for an outpatient procedure.
Yeah.
As an option for awake sedation, I think that they are more alert and more awake, providing that you choose your dose correctly for the patient, than they would be with an equivalent titration of propofol. They certainly respond that many times quickly to command, even though the sedation is still present. Depending on what the procedure is that you're doing, you might need to add an anesthetic or an analgesic, which are under very small dose. And you can then adjust the level of sedation to whatever level is appropriate. You can make the patient completely non-responsive if you wish, as we do, when we're doing a total hip replacement.